Good afternoon, everybody. I'd like to call this meeting of today's Health and Human Services Committee to order. Are there any corrections to the minutes? Seeing none, the minutes are approved. We're going to take today's agenda out of order, so we'll start with 1B. And I'd like to welcome Dr. Alexander. Thank you.
Thank you.
Please join us here at the table.
Oh, okay. So I'm Jim Alexander.
Punches.
Sure. I'm the medical director of the health department. So relative to vaccination, we've always had a role as a health department in vaccinating underinsured and uninsured kids and adults. So as well as kids are eligible for vaccination through our program if they have Medicaid, Fidelis, if they come from one of the tribal nations, they're all automatically vaccinated through a program called Vaccines for Children, which is a federal program administered by the state. We've never really had a mechanism to vaccinate kids who are insured. And it hasn't really been an issue until recently. And what's changed is with the pandemic, the public health emergency permitted pharmacies to start giving vaccines to children. Pharmacists were previously not allowed to give vaccines to kids. And as a result of that, many of the local providers, pediatricians and family medicine physicians, stopped their vaccine programs because they found they were buying vaccine, but they weren't moving inventory because people were going to the pharmacies. And some restrictions on the state level has really forced a lot of the local providers out. And the public health emergency was withdrawn, it ended. The ability of pharmacists to vaccinate children ended. And now we have this huge void. Well, you may know that Onondaga County Health Department, like all local health departments, has a mandated role by the state to vaccinate kids who are going to be excluded from school. And we get 14 days notice on kids who, if we're lucky, on kids who will be excluded due to lack of immunization. So we are mandated to coordinate that vaccination for those kids, but we don't have a mechanism to vaccinate kids who have insurance. We don't have a mechanism to recover the cost of buying the product to vaccinate these kids. Now, we do have a contract with Blue Cross and other health insurance companies where we can charge them a set fee that was previously approved by the legislature for administering the vaccine. But the $200, for example, that it costs to acquire that vaccine product, we have no way of coming up with a cost for that. So what we're proposing, given that last year we had 2 to 3 times the number of kids that we vaccinated compared to prior to the pandemic, and we anticipate that need's going to be even greater, we get our Vaccines for Children product for free, shipped to us from the state, but we anticipate we'll be vaccinating more insured kids. So we need a mechanism to recover that cost. We provided a list of basically all of, except there's one excluded, the vaccines that we would give to children or adults. And we propose that we would like to charge our cost to just pay for the vaccine in addition to the administration fee that we've traditionally charged. And it's all pretty straightforward, I think. It's not a money-making venture, it's just to recover costs and keep kids in school.
Absolutely. Okay, do I have any questions or discussion on 1B? Legislator Meeker?
Thank you, Mr. Chairperson. So what if there's a scenario where a child comes in and they don't have insurance? Will the county bill the parents? Does this cost?
No. We have a sliding scale, okay? And if people are unable to meet income requirements for the sliding scale, they will get immunized for free. Now, the caveat to that, that more directly answers your question, is that vaccines for children is for kids with vanillas, Medicaid, tribal health, and uninsured. So if you don't have insurance, you're eligible for free vaccination through the federal program. So nobody is going to get a bill from us for $200 for a vaccine product plus an immunization cost, an administration fee. Those kids are going to get vaccinated for free. Now, it also covers not just the uninsured, but the underinsured. So if someone has health insurance, but it doesn't cover the cost of the vaccine, which really shouldn't even exist post Affordable Care Act or Obamacare, because everything's supposed to be covered. But if there is that rare kid who is underinsured, they're free as well. So nobody's going to get stuck with them.
So these are typically students whose parents haven't taken them to a pediatrician for whatever reason it may be.
Yeah.
Could be a scheduling thing, whatever the reason may be. Then the school notifies the health department that this student has 14 days or can no longer attend school.
That's correct.
At that point, they make an appointment with the county to come in and get vaccinated. And then if they have insurance, the county bills them. Bills the insurance.
We don't have a mechanism to define the cost.
But once this passes,
Yes,
then
absolutely.
you will bill the
Then
health,
we
if they have
say-
health insurance, you're gonna bill the health insurance company.
That's right. It's a, hepatitis A vaccine for kids costs us $173. We're going to send a bill for $173 to Blue Cross Blue Shield.
Understood. Thank you.
Sure.
Any other discussion?
I'm a little concerned about the delivery. Kevin brought up the point about a student not having the shot. You have 14 days for him or her to get that vaccination
Yes.
in order to stay in school. Is that correct?
That's correct.
So how do we get that kid vaccinated?
Once we get, the schools are mandated to provide us with a list of children who will be excluded, but they're only required to provide it on the day that they've been identified as getting excluded in 14 days. So they don't give us months, okay?
Right.
They give us 2 weeks. By the time they get us a list, it might be a week. So we actively engage the family. We call, we'll reach out to them and say, hey, your kid's gonna be excluded from school. We gotta get your child in. And our goal is to get that child in within 1 day, ideally within a few days, so they don't fall into that exclusion period. We don't want them to miss a day of
What
school.
is in, get them in? What does that mean
We have an immunization clinic in the health department
here?
over in the building next door, where we staff that and with nurses, and people come in and they can receive their vaccines.
So a kid from Fabius would have to come downtown to get that here.
That is the current situation, yes. So presumably these kids have already tried to reach out to their pediatrician or their family doctor, and we ask them that question: have you been able to get in with your pediatrician or family doctor? Because we don't want to interfere with that relationship. So it's only the kids that have fallen through the cracks where they say, well, my pediatrician won't see me anymore because I haven't been in 5 years.
Or the parent or grandparent or whoever the custodian
Yeah,
is not doing their due diligence for that kid's health.
unfortunately, that's the case in many cases.
And so we can't let that kid, fall through the cracks.
No, it's not the kid's problem,
Right.
right? So we're just trying to minimize the impact of, we're mandated to supply the vaccine. We don't want to not be able to bill for the vaccine to the third-party payers who are, they're the ones making money if we don't bill them.
And so they can't go to the pharmacy anymore and get vaccinated?
That's correct.
That's a shame.
They can still get influenza vaccines at the pharmacy, I believe, for kids, but they can no longer get their tetanus shots, they can't get their measles shot, which during the pandemic they could.
Delivery's a problem.
It is. It's a huge problem.
Have we been able to keep pace with the influx of kids that previously have been able to get vaccinations in a pharmacy setting that are now left without that option, or has that been a challenge?
It's been a huge challenge, but there has not been a child who has not been vaccinated. So we've been working closely with Upstate Pediatrics. They're willing to take our kids in on short notice, immunize them, get them out the door.
Do we have any type of door-to-door service instead of having the kids come in, or any type of, I know there's Medicaid caps, but these people that are uninsured or fall into the cracks, as you say. So is there a solution to those who, in the transportation issue?
So we're doing a couple of different things. Last summer, we actually tried to, in partnership with the University of Pediatrics, we tried to hold vaccine clinics at the schools and over the summer so that kids could get immunized before school starts. Unfortunately, that was shut down by the State Department of Health. We've been working with them for an entire year now because we didn't have a certificate of need to do that. The state has since changed their thinking and said, oh no, you can hold those clinics. So to the extent that we can coordinate it and it's needed and things, we can go into the schools. We also now have a mobile vehicle that has not yet been authorized by the state to provide medical care. But as soon as it does, one of the big plans for that vehicle is to provide vaccines. And it'll get, access to this kid in Pompey. It'll get access to the kid in Elbridge, and as well as throughout the city. And, bring our services to them. Because the transportation, again, it's not the kid's fault, right? We still have to have the parents sign off, but yes.
If I could play the other side of that for a moment, because I understand, I can relate where you're coming from and ease of access and, but the flip side of that could be parents who are not bringing their children to get their vaccines could be a parent that's, a checkup is important, right? The child to be physically checked up by a regular doctor. That kind of, a mobile mechanism takes that checkup away, because typically when they go in to get their vaccines, they're also being talked to by the doctor, they're being seen by the doctor, and they're getting their physical. That mobile piece takes that piece away. That could be concerning.
So we're trying to serve the need as a safety net provider. We are communicating to every family that we are not your doctor. We are not the one who's doing developmental screening, child checkups, and you really need to establish care with a pediatrician. We're trying to close that gap between identification for exclusion and exclusion. And we're not trying to take the role of the pediatrician. We want nothing more than for these kids to see their doctors. And they need to. They just, some cases are more challenging
Right,
than others.
it's a tough spot,
Yeah.
because you want them, but if they get their vaccine, then there's no other reason for them to legally really have to go be seen by a doctor.
That's correct. The carrot is, we'll keep your kid in school if they're up on their vaccines.
It's a tough spot. I'm not saying I have the answer, I just playing both sides of it.
It is a difficult position, but we don't want to keep kids out of school
You're too young to remember when we were in school, and by classroom, we would go to the gym and bingo. They would be giving us shots after shot. We'd go back to the classroom and see who the first kid was that fell out of the seat because they passed out. But that was the approach they took previous generations when it came to the shot. Now, if you were a Christian Scientist or you had another exemption or something, they honored those, type things. But the delivery was there. That was key. No.
Well, yes, but there's been changes in consent requirements.
Mm-hmm.
I can't just go vaccinate a room full of kids
Yeah.
without their parents signing off on it. And, 15% of those parents are gonna say no.
Right, yeah, well, that's always been the case, so.
But,
And now I have a motion from.
So, just a question as far as something, the last local law, local law 7 from 2018, I'm talking about the cost. I understand that cost, a number there, which I thought was interesting. The other law that we had numbers there. I'm not going to assume. So is there a reason why there's not numbers here?
we were seeking compensation for administration of a vaccine. Sticking a needle in an arm, we can say, hey, a reasonable amount for that, $25.
Yeah.
If we're buying a vaccine, it may be $100 today and $130 tomorrow and $70 the next day. Right. And it all depends on the supplier and the inventory and whatever the pharmaceutical companies are doing that week. So this allows flexibility for us to look at the invoice and say, well, here's what it cost us, that's what we're gonna charge. And otherwise, if I said I want $100 for this, I'd be back here next year, next week.
Right. Yeah.
Just wanted to pose the question why, and don't want to assume the answer, but thank you.
And based on what you've said, that's exclusively the administrative component, is that correct?
That's correct, yes. Yes.
Okay, I have a motion from Legislator McCarron. Do I have a second? Legislator Meeker, all in favor? Aye. Any opposed? Okay, motion carries. And we will go back to item 1A.
So item 1A is, there's a consulting firm that has done consulting with health departments on the utilization of what's called community health workers, which are individuals from the community who have ties to the community and are able to access individuals within the community as a peer rather than approaching as, say, a nurse or a doctor. And there's many health departments that have had success across the country using these community health workers who are trained by the health department to go in and assess and communicate and get the story in people's homes about how are you doing with your newborn? How's the breastfeeding going? Are you sad? Are you feeling anxious? Are you, any number of issues. How's your scar looking from your C-section? And the access to a community health worker is really fantastic compared to the access of an unknown member from the profession who's trying to get that access. Now, unfortunately, in many members in our community, they may never go back for a postpartum exam. You don't see some women from the time they're having a baby until the time they're pregnant again. And so we don't know what happened in their postpartum period. We don't know, what's going on with their kids and developmental things. And so this offers another opportunity to place community health workers within that home environment. The problem is we have some experience with community health worker placement through the health department. We've contracted it out through other local agencies like Peace and some of the other groups. This consultant has the ability to work with us and tell us how to best roll out such a program and what the needs are and how we define our priority populations in order to bring equity, in order to reach certain communities, certain of the communities of color and refugee communities. And, you go into some of these homes and they speak Swahili, and that's hard. And if you have someone from their community who also speaks Swahili, you can get a much better story, maybe if they have the training to help us communicate. So this consulting firm has offered consulting up to a certain dollar amount, in this case $53,000, to help us establish this program. The other motivator here is that even if we wanted to send nurses into the homes, since the pandemic, there's no nurses to be had. They're hard to come by. There's fewer people going into nursing. The nurses are being hired up by the hospitals at rates that we simply can't compete with. So this is hopefully to push us in the direction and get us to establish a health worker program for desperately needed services.
I see here that it's a 6-week intensive engagement with the health department. Are we anticipating some product after that 6 weeks? Will there be a period of delay following that for them to compile their results? What's our timeline as far as receiving results from the study and then any potential rollout?
I can't answer that question.
Okay.
But there'll certainly be motivation, I'm sure, on both ends to
Sure.
expedite the process.
Okay.
Is the consulting service doing this as a gift to us in hopes of getting a contract with us post-consultation?
Yep.
Thank you.
So what's the reason for them to, if that was my thought as well. I can't see any reason why, other than what Legislator McCartney said. Why would they want to do this?
I don't know if they're, I don't know, but motivation may be that they're grant funded, that to help roll out these programs across the country, because that is a goal of the federal government, is to establish more community health worker services. So I don't know what their motivation would be otherwise, but certainly I would anticipate that if they are looking for a future engagement, we don't have the money for that, and we would be going back to this table to look for money to supply that.
And the name of the company is ZS Consulting, right? So at minimum, what the county and your office will get out of this will be great knowledge of how to move forward and what to look for at minimum.
Absolutely, yes.
At the current time, using your example of the people that speak Swahili, do we have anyone to do that role right now?
We don't. We actually have someone in our tuberculosis program who speaks 5 or 6 different African languages, and we pull him in a pinch. But he's not medically trained other than what we've taught. We have language line, which can help us communicate through an interpreter. But the challenge there is you call them up and you say, if you say Swahili, they're like, oh yeah, that'll be a second, we'll get somebody. We've had people who speak certain dialects that, we have this guy with a Mayan dialect from Guatemala. And we had to go to Los Angeles to find somebody who spoke his dialect. And, so that's not a 1-minute connection time.
Well, it seems like at minimum, like I said, your department's going to gain some knowledge from this program and see what other directions they be able to move into the future for some. Our refugee population is growing.
It certainly is.
So
we have Erie County and Onondaga County are tied for the most number of refugees coming into New York State on the county level. So we're getting a huge number, and we don't really, we just kind of send them, and we understand the importance of caring for people. But we didn't budget for this stuff because nobody knew they were coming.
sure. Mr. Chairperson, if there's no further questions, I'd like to motion this one.
Okay, I have a motion from Legislator Meeker, second from
Second.
Legislator Harvey. All in favor?
Aye.
Any opposed? Okay, motion carries. Yeah, certainly looking forward to the work product and seeing what efficiencies we might come up with. So thank you, Dr. Alexander, and I'll adjourn this meeting.
Thank you.
Thank you, Doctor.
Thank you.